Thank you. The term habilitative services, which, as I understand your testimony, we can mandate habilitative services and not run afoul of the rule because it's declared to be outside the rule. Mm-hmm. In looking at the language for habilitative services, it wasn't clear to me whether that includes rehabilitative services. It talks about keeping and improving. If it's a question of restoring someone's abilities, is that covered by the word?
No, I mean, habilitative and rehabilitative are separate. Do you want to talk about that?
No, go ahead. That's fine.
Yeah. Rehabilitative and habilitative are separate and distinct. The idea of rehabilitative, as you note, is to allow somebody to regain something, a function that they previously had. Rehabilitative services have been covered previously in New York. And habilitative services, by contrast, are where you're trying to gain something new or keep something that you have, but it's really trying to gain a function that you haven't lost necessarily. And so basically the state does have, because habilitative services haven't been defined, the state does have quite a bit of discretion. In the federal guidance, the limit on that discretion was just that the state should use a reasonable interpretation as to what habilitative services are. So, and the feds haven't really gone into any more detail than that. Well, what does a reasonable interpretation of habilitative services mean?
But if somebody wanted to add, or if some other state wanted to add a benefit, and it was clearly an added benefit, and it was something properly called rehabilitative services, would the habilitative services exception not apply then? Because it's rehabilitative?
Yeah, I think that's right. And rehabilitative services are covered. I mean, that's one of the categories of essential health benefits, and so rehabilitative services are covered, and are covered under our essential health benefit plan. Are one of the 10 categories that the feds require to be covered. So I guess where it could come up is, I mean, it's a broad category, rehabilitative services. If a state didn't require rehabilitative services, but
rehabilitative, for the purposes of that federal exception, is not a subset linguistically of the word habilitative. It's
Correct.
A separate animal.
Correct.
Okay.
I would just add, and in fact, Chairman Gottfried, I believe the federal law actually lists them separately among the 10 services. So rehabilitative, I think, is at least from my understanding of it, is a place I think where we've gotten more evolving federal guidance on definitions and what ability the states have to define that benefit. There's actually been subsequent guidance on habilitative and coupled with, I think, this more recent rule probably, in my view, provides the flexibility that rehabilitative does not from the standpoint of the state.
Okay. We often in legislation include a severability clause that says if any provision of this statute is held to be invalid, that will not affect the rest of the statute. And in the Medicaid law, we often say that such and such is required under Medicaid as long as there is federal financial participation. Do you know whether any state has included in a bill dealing with a benefit out of concern that it might be deemed to be an added benefit, something kind of like a severability clause that says that if this benefit or any application of it is deemed to be barred by 45 CFR, et cetera, then it shall be null and void. Do you know if anyone has tried that?
I don't know. If I understand, though, your question correctly, you're, I think, drawing, Chairman, an analogy to the availability of federal participation for a Medicaid service or initiative. I don't know. We can certainly try to find out, but if any state has had an insurance mandate, it sounds like enacted, they would have a contingency on it going forward. I guess that contingency would be that the state doesn't need to pay for it, or conversely, that the federal government agrees that it is part of the EHB benefit and doesn't result in an additional state cost. Do I have it conceptually? Your question conceptually correct?
Well, what I'm thinking about is if you're enacting a mandated benefit and you're worried that the state might end up having to pay for it, it would not be hard to write a sentence that says, if we're going to have to pay for it, it's null and void. And I'm just wondering whether any state has done something like that.
We will work to find the answer to that question. We will work with other states and other state marketplaces to see if we can get that answer for you.
And just my last thought, the Chairman Cahill's question as to whether 1332 waivers would require legislative authorization. I think I know the answer to that. If you're trying to do something that you have, from your viewpoint, darn it, regrettably concluded you don't have authority to do without talking to us, you'll come and ask us for permission to file the waiver. If, as you would almost always conclude, you don't need legislative authority to do X, but you do need a waiver, you'll just go and apply for the waiver. There in using the Medicaid analogy, there are plenty of lines in the law that direct the health department to apply for any necessary waivers. But I think the really big Medicaid waivers that New York has gotten over the years were entirely the invention of the executive branch and came as news to the legislature. So that's just my observation over the years.
So there, huh?
So there, right?
John, did you want to?
So there to us.
I wanted to give Assemblyman McDonald a chance to say hello, but he'd like to still defer and wait a little bit longer to do that. So we will go to my good friend and ranking minority member of the Assembly Insurance Committee, Will Barkley.
Thank you, Mr. Chairman. It tells my mic. There it goes. Some are kind of broad questions, then Troy, I have a very specific question I didn't understand, so maybe your testimony. Just generally on the bare bones essential health plans that are offered on the exchange, are they more comprehensive then or less comprehensive than what you would get under Medicaid in New York State?
I don't know. Do you want to answer that, Donna?
Sure. There are under federal law and rule and state law as well, there are certain services that are covered in Medicaid that are not covered by most commercial insurance, including the policies sold on the marketplace. So let me give you an example. Over-the-counter medications covered in Medicaid, non-emergency transportation, so transportation to your appointments, your doctor's visits, the medical services you need, are covered under Medicaid. None of the 10 benchmarks in New York, which I think reflect employee plans, both state and federal, and the largest HMO in the state, as well as small group, cover some of those services.
But generally, am I correct in saying that the Medicaid program is probably more expansive than the bare bones?
There are, by bare bones, if you're asking, are there services that are covered by Medicaid that are not included in the EHB or generally available in commercial insurance, I think the answer is yes. under federal and state requirements for Medicaid.
What percentage of people that are taking advantage of the exchange? Can you hear me now? How about now? There we go.
There we go.
Back up, everyone. What percentage of people that are taking advantage of the health exchange or they're taking part in the bare bones essential health benefits coverage? So obviously you can get more coverage if you want on the exchange, if you want to pay more, but do you know the percentage of people doing the bare bones one?
Yeah, I can give you some rough estimates. So what we describe as standard plans offered on our marketplace include the essential health benefits, and they are the basis for the calculation of the tax credit. Those are the most popular plans. About 37% of the people who buy qualified health plans in the individual marketplace, these numbers only pertain to individual. I don't have the small business marketplace numbers off the top of my head, but about 35 to 37% of the individuals who buy in the marketplace are buying a non-standard plan. Some portion of those have additional benefits. Sometimes there are actually different configurations of cost sharing as well. So we can dive deeper into that 35 to 37% and get back to you with an answer. But the majority of consumers we see are buying standard plans. I think that for the most part, what we hear from consumers, this is anecdotal, is that those benefit configurations are meeting their insurance needs generally. The plans that are non-standard that draw, I think, the largest interest are the ones with dental and vision. In fact, there are plans throughout the state, several in New York City, several upstate, that are offering adult dental and vision as an option for those people who want, in this case, to pay the additional premium for those services.
And I thought I understood from your testimony, maybe you can explain how the federal government changed the way they were going to consider. At first, they were just going to mandate what essential health benefit plan is, but then they allowed the state some flexibility, and you had a criteria of the 3 biggest federal plans and the 3 biggest state ones. How New York, and then you said, well, we chose the one that had the most benefits at the least additional cost. Is that correct? Is essentially how you came up with the Oxford?
Just to be clear, the federal government didn't express a will that they were going to just pick one benefit plan for the entire country. I think what I was saying is the federal law, the ACA, gave the Department of Health and Human Services the authority to define what that federal benefit minimum would be. I think a lot of us, I know a lot of us in states, other state regulators certainly were thinking, oh, the feds are just going to create one package that's going to be the minimum for the entire country, but that's not what they did.
Right.
And they gave states flexibility to choose among those different 10 categories, and as Donna went into some amount of detail, we had a very lengthy stakeholder engagement process with hearings in different parts of the state and meetings with the industry, certainly with consumer groups, provider groups, all weighing in. And we tried to, as Donna said, the choice we came up with, which was the predominant choice that most states came up with, was the largest small group plan because it struck the right balance of being quite comprehensive, but also not pretty consistent with what a lot of people already had on the ground, and so therefore not generating a lot of additional costs on at least on the benefit side.
So other states have chose the same small group plan to be their essential health benefit plan. Are they all the same type of coverage then in those, or are we more comprehensive in New York versus others?
No, I mean, if I could, I think, certainly, my thinking on it was that, to come up with a one-size-fits-all set of covered services nationwide would have meant that some states, it depended on where your starting point was as a state. So for some states, I think, if they were to augment what they were offering to New York, they would have had to, increase the coverage. If there had been one nationwide one-size-fits-all that was had less comprehensive coverage than New York, we would have had to change right to that state. So I think the options that we have are state specific. So when another plan picks the state employee plans, the largest employee plan, or they pick the small group plan, it's of their state. So each state did an analysis that identified which specific 10 plans they were. Information about those plans was submitted to CMS, where I think it's made public. So, for example, when Massachusetts or another state that uses small group picks their plan, it's their plan, not our Oxford plan.
Right.
So there will be some variation. I think to some extent the 10 categories of service that are required to be covered by federal law have standardized the variation in some respects, though, from state to state, because we must all cover those regardless of what the state coverage was before.
Okay, great, thanks. Troy, just on your testimony where you're talking about the new Health and Human Services rules that they implemented in March in 2016, the second, you mentioned this is very important, the second bullet point there. I've read that 3 times and maybe I just can't focus. Can you just explain that one again for me? I can't understand it.
So the idea is, let's say, you're in a state that doesn't cover rehabilitative services, right? There's no requirement for rehabilitative services, but that's one of the categories that is covered under the benchmark plan that you pick. So you pick the largest small group plan in your state that didn't cover that covered rehabilitative services, even though there's no mandate in your state to do that, because small group employers wanted that, and that's what insurers offered. If the state would subsequently enact a law to require rehabilitative services, even though it's already covered in the state benchmark plan, the EHB plan, the federally required plan, the state would have to pay for that fully because it's now a new state mandate, even though it's already, I don't know if that you followed that.
And even though it would be mandated already by the ACA?
Yep.
And what's any logic behind that? I mean, I guess that wouldn't really apply in New York because we already had all the coverage anyways, so it's probably not, does it apply to us at all?
No, I mean, I think we're not in danger of that, but it would say to a state that didn't that there was something in the benchmark plan that wasn't required by state law. If you newly required it by state law, even though it's in the state benchmark plan, you would have to pay for it. Right. Why did the feds do that? I'm not sure I know why they
save money. They don't want to pay for it, I guess, right?
Hearing aids? Yeah. Okay. Hearing aids, I guess, would be one that in New York we could apply. Yeah.
Okay. Thank you. Thank you,
Sure.
Mr. Chairman.
It's interesting. I have a bill called the Comprehensive Contraceptive Act. It's got a longer name than that, but that's basically what it is. And it includes essentially 10 areas of coverage. It's in the mandated federal benefits. Contraception is part of the mandated federal benefits. There's also a benefit that was included in our benchmark plan that was not part of the federal mandate. And the legislation was drafted largely by the Attorney General of the state of New York to assure compliance with the federal government and the benchmark plan. Is it your testimony that by making that legislative as opposed to the way that it has been done administratively, that it would then become a cost to the state of New York? That's not my understanding, but if that's your understanding, we're going to do some more research on this.
Okay. Well, as to any specific bill, I think we'd like to take a look at it and
okay, so let's not be specific. Mm-hmm. Let's just say that something is covered under the federal required benefits, the 10 essential benefits that the federal government lays out. Contraception is one of them, but let's just say it's any one of them, and that a package of legislation is put together that covers those benefits, basically saying this is how you comply with the federal law in New York State. and that in addition to that, to round out the package to make sure that it is truly comprehensive, something is plucked from the Essential Health Benefits Plan and stuck into the legislation. Forget the specifics. Is it your testimony, both written and oral, that would then trigger a state cost?
Yeah, I mean, my understanding is that if it was required under the federal benchmark plan, and there was not a state mandate, and then we issued a new state mandate for that benefit, whatever it is, that my understanding of the federal rule that came out is that there would be a state cost to that.
I actually had that very same question that Will asked you about underlined on my list from your testimony, and if you could provide us further explanation of how you arrived at that conclusion, it would be very useful to us, if for no other purpose than for statutory construction.
Sure.
So I'd be very interested in having that information.
Sure.
Excuse me if I'm a little disoriented. I'm still trying to get over the fact that Dick Gottfried invoked Justice Scalia, but we'll deal with that in a little bit.
But not in a favorable way.
Oh, I don't know about that. Depends on your point of view. I just want to go over a few other questions. In determining what is or is not a new benefit, you demonstrated and you testified as to a process and a series of standards that would be imposed. And I believe you started out by saying that the insurer starts by telling you. You start with the insurer, and then you go through Millman and a variety of other processes to arrive at a conclusion of whether there is an additional cost. Is the same process in place for health procedures as is in place for new medications, new prescription drugs, or other medications? Do you follow the same protocol no matter what?
Well, just to clarify, it really is the state that would determine whether or not something is a new benefit that would incur a cost. It's up to then, once we've determined that there is a cost, the insurer figures out what that cost is.
Right. You start by determining, it is up to us to determine that there is a cost, but once the determination is made, I think you indicated that the first step in the process is that the insurer does a calculation and submits that calculation to you to tell you what it is.
Yep.
Right? So it's up to us in the first instance to determine that there's a cost.
Right.
And there has to be, of course, a rational basis to that determination.
Yep.
And if we determine that there is no cost, what is the process by which the insurer or other parties might appeal that determination?
Oh. Yeah, I'm not aware of an appeal process.
That's good news
so
to
I think
me.
I think they would just complain to the Department of Health and Human Services, the federal government, saying that New York has not properly interpreted the law, the federal law, and that there is a cost, that this is a new benefit that would require the state to defray the cost.
You think that they would take their case to the Federal Department of Health and Human Services? There is no state process for appealing that determination, right?
Yeah, I guess potentially an Article 78, taking the department to court or appealing to federal regulators.
Okay. So there is no procedure in place once that determination is made. What if that determination was made in legislation? What if there was a legislative finding in the bill that created the new mandate that said, by the way, we've determined that this has no additional cost?
I guess that would be subject then to federal or court review. But yeah, I guess.
Okay, so the initial determination of whether there is an additional cost is one that is rendered by the state, and by the state it could be legislative, it could be administrative, or elsewise.
Yeah, I mean, it did. The federal rule didn't specify who in the state. It just says the state. So yeah.
Well, that brings me to another one of the questions that I had before I came here today, and that is: are you aware of any states that have that have allowed or required additional mandated benefits over and above their essential health benefits plan that incurred a cost to the state, or how they handled avoiding that cost?
I'm not aware of any.
Yeah, I'm not aware of any either, but I think along the lines of Assemblyman Godfrey's question, we're happy. We will try to get that answer for you.
Yeah.
And at the same time, we'll try to understand whether or not that state's mandate included any language that, as we talked about earlier, that would make, I guess, the mandate not take effect if it triggered a state cost. So kind of two-part question. We're happy to reach out to our colleagues in other states and DFS as well. We're happy to reach out to HHS as well.
Great. Just trying to go through some of the questions I have here. You indicated that there was a stakeholder process by which you arrived at the determination of what the essential health benefits plan should be starting in 2017. Is that process now closed? I know you've selected one, but is the process now closed for?
Well, we certainly are open to hearing concerns about the EHB, throughout the year. The process was open and it was closed because we had a requirement as a state to notify HHS as of a date certain what our selection was. They then took each state's selection, EHB selection, and they published it in a federal rule for comment. So that opened a federal comment period under the notice of proposed rulemaking. In fact, there was, however, I'm not certain how long that period was. At the end of that comment period, HHS published the final rule that includes state-by-state selection, and it became final for 2017. At this point, we are waiting to hear from HHS when that next selection period begins and ends. But we're certainly open to hearing concerns and comments about EHB throughout the year, and we always look at those issues to see whether or not, when we look at them on a case-by-case basis, it's actually, something that is inherent in the EHB decision or the limitations in the federal rules around EHB, or if there's another question, it might be a question of whether, definitional question of a category of a service that is covered. So I'd like to, we certainly like to work with you and with constituents on those, on the specifics.
The selection of the new benchmark plan, how long will the new benchmark plan be in effect?
There is no set term. It's, I guess, until the Department of Health and Human Services tells us that there's a new selection period to be made. Yeah, I mean, there's no, they didn't say it was good for 1 year or 3 years or any defined
Initially
term.
they did, right? With the initial selection, they said you have to pick a new one on 2017.
Correct.
Okay. So in 2012, you selected Oxford, and it was, I think it was Oxford, right?
It was the Oxford Direct, the EPO plan.
So in 2012, you selected Oxford based upon the benefit configuration that they developed in 2011. So in 2016, you're selecting Oxford again. Have they changed their benefits?
Yeah, I think there's one change, and I'm going to look back here to our DFS colleague. I think there's one change in the detail of the benefits of the benchmark plan, and it related to a change in visit limits for PT, OT, and speech.
Yeah.
For the period 2014, 15, and 16, the benchmark plan had a limit that was per condition per lifetime, starting in 2014, because for 2017 it's based on the 2014 benefits. That underlying benchmark plan was changed so that the limit is more generous in that it counts visit per condition per year. So that'll be reflected in the 2017 coverage.
Okay, so
that's the only change I'm aware of in that benchmark.
In 2017, the essential health benefits plan will change in that certain PT and OT services will be, that the policyholders will be allowed more visits.
That's
Right? Other than that, everything's the same as it was in 2011.
Yeah, basically, yes.
Okay. In the assumption of cost by the state, is that forever or is it just in the first year?
It's forever.
It's forever. Okay.
Yeah. Assumption is forever.
So I just want to be clear that if a determination is made that a new medicine is available or an uncovered prescription drug could provide better care, better outcomes than the existing benefit coverage plan allows, and that drug costs, let's just use some outrageous numbers, that drug costs $1. And that it will save $1,000, but not necessarily in the first year. Is it your testimony that that new drug cannot be covered unless the state is prepared to pick up the cost of that drug?
My colleague
Yeah, no,
was
no,
just confirming that basically a drug is based on the formulary. Drugs are covered, right?
Right, but so say something outside the formulary.
If it's outside the formulary, it would be subject to a medical necessity that the drugs inside, that are within your formulary are not adequate.
So the question was not necessarily about, the question was more about the amount of time it takes to balance out the costs. If the cost could not necessarily be recovered in a single year, but it might be something, say, over the lifetime of a patient, say, prevent the need for a liver transplant or prevent the need for dialysis or something, and the use of this drug now could prevent that over the course of the life of the patient, or even over the short-term life of the patient over the next several years, but not in that first year, couldn't necessarily avoid additional costs in the first year. Is it your understanding, the department's understanding, that that would be one of the enhancements of a benefit that would require the state to pay for it as opposed to mandating it without additional cost to the state of New York?
Well, I guess, and feel free to chime in, Donna, but the way I understand it, drugs are broadly covered. If there is a drug that's medically necessary.
Troy, but my hypothetical is saying you're going outside those realms where you can't fit it into one of the existing protocols or exceptions. But it makes sense, but the sense only applies if you go beyond the policy year.
Okay, so I want to make sure I understand your question.
Yeah.
You're basically saying something that is not necessarily a medically necessary drug, but would, in this hypothetical, would end up helping the patient in a way that would save costs down the road.
Yes.
That would. And the state would, the question is, would the state still have to, if they mandated coverage for that drug that wasn't on the formulary, that wasn't necessarily medically necessary, that the state would still have to defray it, even though the costs might be better to the patient and save costs down the road? Is that essentially your question?
Yep. Same question I asked before, but I'm trying to bring it to the point of absurdity on purpose.
The short answer is I don't know.
Yeah. If I could, I mean, the one clarification I would make is that the way the essential health benefit rules work, the coverage isn't matched drug for drug. There's requirements that we didn't talk about today in the federal rules around the essential health benefits having to have, an equal number of products in each of the categories of drug that were covered by the benchmark. So it's not necessarily a drug for drug. It is not a drug-for-drug match. I think, if I understand, Chairman Cahill, your question, I think, goes to whether or not HHS would accept an argument that even though that a new technology or a new drug that wasn't in the benchmark, 2 years ago, if they'd accept an argument that by covering that and adding it to the benchmark, there would be cost avoidance in future years, should relieve a state from having to pay for that additional service. I think if that's the question, the answer is I don't know. I don't know if that is an argument that they have been presented or that they would entertain. But if I understand it correctly, it's that in future years, costs could be avoided by adding benefits, whether it's a new category of medication or a new technology or a brand new category of service. I can't think of one of those off the top of my head. But that is, I don't think we know that. We can certainly see if any state has asked that question, if in fact I have the question right.
And I don't mean to interrupt. So let's just take for the moment that even in the most absurd of circumstances, a $1 drug will save you $1 million over the life of a patient, but doesn't save you anything in that first policy year. That's a crazy concept, right? But it's not so crazy if you start to think about a $450 drug versus $1,000 savings over the course of a patient, but the concept is exactly the same. It's just been a part that I've had a lot of trouble getting my arms around. Is that anyone could have decided that we should freeze healthcare in a particular year, especially given the rapid advancements that are occurring in healthcare in so many different ways. I mentioned prescription drugs, but genetics are unbelievably advanced compared to what they were even 5 years ago. We understand protocols. I'm involved in trying to advance the funding for a program called the Spinal Cord Injury Research Program, and the intense, repetitive robotic therapy that's involved in that wasn't even thought about 5 years ago, didn't exist, but now it's allowing people who had no use of their limbs to use their limbs again. It's certainly not a covered benefit. I mean, even under the expanded Oxford benefit for OT and PT, it wouldn't allow for 6 hours a day, 6 days a week for 6 months, which is what that robotic therapy calls for. But it works. And it takes someone who is possibly quadriplegic and it makes them able to use their extremities again. It's something that again, may be sort of an extreme example, but the question is, do we have a means by which we can account for the advances in healthcare when it comes to the coverage that we are going to mandate our insurers to provide, or are our hands tied to a 2011 model? And everything you're telling me so far is it's essentially our hands are tied to a 2011 model with two potential exceptions. One exception being the selection of a benchmark plan that includes expanded benefits, and the second being the potential use of a 1332 waiver to secure permission to expand those benefits beyond. Are you aware of any other means or device that could be used to keep healthcare modern in New York State? Because, I mean, it's bad enough it's 2016 and we're using an 11 model, but Troy, you just said that the new benchmark is to infinity. And I wonder how my grandchildren will feel in 2030 and 2040 when I tell them that they have to use 2011 technology because that's all their insurance is allowed to cover.